I recommend diagnostic-wise, after taking thorough history, medical records, and again, go back into developmental phases, early life. I pretty much take a history by the 3-month cycles up to age 1, and then yearly cycle from year 1, year 2, and so forth. When I take histories, looking at medical, social, and other kinds of factors, educational issues, each domain over each year is important. Because what I'm trying to do is put together this picture of where the child has disinhibition, arousal problems, and where the child doesn't. And also then an age, and when are they really present. Behavioral rating scales are very important. Okay, they're very helpful. But remember, behavioral rating scales just measure the behavior of someone who may have a problem with disinhibition and may have a problem with arousal. They don't measure ADHD. Okay. Now, the only I would have to caveat on that is that the short version of Keith's test, the Connor's short version, really is the DSM-4 checklist. At that point, I guess you're measuring ADHD because that's what a DSM-4 checklist is. Okay. But most of the long forms not. I would encourage you to use a rating scale that does not just measure ADHD symptoms alone. And by that, the reason is that you will have to remember it's by exclusion. You have to exclude everything else. Okay. So I prefer the scales like Alkenbach's CBCL, Reynolds and Camphouse's BASC Behavioral Assessment System for Children. Okay. Because, again, what I like to stress is multi-trait, multi-method convergence. Remember those things we learned in those psychometric classes? Dear Annie Anastasi taught us. Those are important things, multi-trait, multi-methods convergence. They also that eliminate things that it's not. Okay. So the good thing about the BASC is that it looks at depression, it looks at anxiety, it looks at other atypical behaviors, things like that. It looks at psychosomatic symptoms and things like that. And what's nice about the BASC, it tends to be an item pure scale, okay, in that sense. And by that I mean the items only go to that one scale. It's very much in the CBCL model. The good thing about the child behavior checklist is those items also just go to those scales. It also has some things about externalizing behaviors and things like that. The good thing, again, it's multi-trait in some sense, and you're also getting multi-method. You're getting parent response and teacher response. And hopefully all of you are familiar with the literature that says that on behavior rating scales, typically parents tend to rate the children higher or worse, that's good language, but poorer than do teachers. Okay. But do pay attention. Don't just shine it off because the child's response from the parents is really high and the teachers is low. That still is a clue. Take a look at that. Use some CSI skills, the data never lies kind of thing, okay, for yourself. Take a look. At least ask questions about it if it's high from the parents alone. But be aware that they tend to elevate a little bit higher. I encourage you to have a measure of sustained attention and impulse control, and that's what we're going to talk about after the break, is continuous performance tests. I really like those, especially I like the TOVA a lot, since that's my test. Medication. And then I encourage both of these being used with medication follow-ups or treatment follow-ups. You want outcomes as well. So these procedures are helpful with outcomes down the line as well. Again, talked about these here, the CBCL, the BASC by Reynolds and Campos. Again, what's nice is, and then in the school years, from about 7 to 18, the child can also fill out the form. So you get a third level with the BASC going in, which is nice. So you get the self, you get the parent, and the teacher reporting. So it's a nice, and there's different norms for each one of the tests. It's well done. And on that model, I'd encourage you, it's the 10th year, and they just come out, it's out this month, as a matter of fact. Reynolds and Campos have a nice clinical guide to the BASC. It's by Guilford Publications. It's an excellent textbook looking not only the literature review of the behavior assessment system for children, but also clinical guides, how to use it. If this scored, it's this, think this kind of a way, which is very helpful, very helpful. The other part is the BASC have done a nice discriminant function analysis to look at which of the BASC items tend to best predict ADHD. And so they do have this ADHD predictor scale now associated with the BASC. I'd encourage you to take a look at that. And I think what AGS, the Publishers American Guidance, have done is they've carved out this factor as a separate kind of test that you can use also for yourselves. Again, that would be nice in the sense of balancing a scale, but I would encourage you to use, obviously, more than just one thing because there's a lot of steps involved. Okay. Let me kind of hold off on this. Let's do some summary. What have I talked about? Well, I opened up by saying we really have to take a look at our theoretical orientation to ADHD. We clinicians really have to have our own, at least a favored model. Because if we're going to do workups and make a diagnosis, and we're going to treat them, it's best that we have a theoretical orientation for both of those. Ideally, they're both the same, but not two disparate ones. Okay. So we're talking an ideal world for ourselves. When we look at that, we have to take a look at the histories of those models as well. So we talked about some histories, but we looked at there are two dominating themes currently in the ADHD literature, and typically what I find in the clinical field. One is that ADHD really is a primary disorder of inhibition, secondary of arousal. Okay. The second one, that's Tom Brown's, is primarily arousal. Disinhibition is overrated. Okay. We also took a look at some historical links to both of those models. We talked about the psychiatric model, which uses primarily arousal. We looked at several models that looked at inhibition and the neurodevelopmental pathways to lead to both. Okay. We kind of capped that by looking at Luria's model as a nice structural unit to take a look at that with interactive feedback loops. There are alternate models as well. But that provides a nice loop model for ourselves. And we looked at and said that ADHD really has to have some disinhibition and arousal problem for ourselves. And it has to be there before age 7 if we look at strict DCM-4 criteria. And it cannot be caused by something else because there are other pathways that cause those problems. That's why going back to histories in early childhood are very, very important. To take a look at those predictors for ourselves. But we really need to, again, remember in summarizing that inhibition really is a process of neural development. We as organisms continue to grow and develop inhibition pathways for ourselves. Now, of course, that's where we differ a little bit from our Freudian friends who talk about the id and the ego and superego. I'll just let go of that. But these common pathways are there. We have to develop more for ourselves. Those are important to take a look at as you look at children. Take a look, where did that problem begin? Okay. It needs to have begun in early ages. It may be that they develop these symptoms around at a certain age, and it may well be that these symptoms develop after sexual abuse or something else. Do your homework, folks. Take a look. Okay? Don't exclude that stuff. Okay? But up until that point, if everything was going well, and afterwards things are different, it's probably not ADHD, folks. Okay? If you have inhibition at age 3, 4, 5, and 6, and suddenly you lose it at 9, something happened. Find out what happened to make the difference. Do linear histories. Okay? Again, neurodevelopment, these pathways are going to bring you to inhibition in a real world. ADHDs tend to live in a different world. Okay? Inhibition is not something they're big on. Okay? And having said that, bear in mind, the other thing they're classically known for is their inconsistency. variability, as we like to call it, variance. Then we have a nice mean of behavior. Good. Look at the variance, the standard deviation, okay? Don't just look at the mean of the behavior. Look at the variance. That's what's important also. It's the variance that predicts, not the mean. It always predicts. And then we began to take a look at some developmental reasons for that. We capped it with Leark, and we came back then to Barkley and Brown's model. Both have strengths, but they're two major roads. One is inhibition and arousal. One is just arousal, and the problems can begin after age 7. Those are two theoretical orientations to take a look at, because your treatment then has to be based out of those models. Treatment needs to be based on treating inhibition or treating arousal. If the psychotherapy models you're doing, and again, ADHD children, as I alluded to in my comment about my German characters who always want to look at analytical models first, you know, I can't imagine doing psychoanalysis with an ADHD child. I guess it'd be good revenue, because it's going to be a while. But it's really not my preferred model. Okay? They don't have the inhibition to do it. Okay? Woody Allen hasn't done it successfully. Don't expect an ADHD kid to do it. Okay? And then we walk through some suggestions for testing and what we want to do. And we're going to spend now some time really looking at continuous performance tests, strengths and weaknesses of them all. Okay? And we're also going to practice arousal by getting ourselves some coffee. Thank you for being inhibited anyway. Although we may not have time to cover all 75 slides that I have left, because there are some dialogues that I love the conferences because of the enriched dialogues that are created around coffee urns. And it's wonderful, and I want to continue some of that dialogue, and I think the community may want to engage on a little bit also, because it's very helpful for us at that point also. So we're going to have some people trickling in and out, and I think as with most conferences, we have kind of conference hoppers. You know, not that any of you, when you were a kid, would have waited in the bathroom until the movie started and gone back in between matinees. But there are some interesting dialogue. I'm going to switch. Good. Certainly hope I had this off when I went to the bathroom. It just dawned on me. One of the interesting dialogues is that, okay, where are you going with this? Well, is there really a difference when you get down to life? In my usual scientific way, yeah, probably. I think we have to take a look at that. Are we saying that, for example, allergies don't produce ADHD? Well, technically what I'm saying is allergies do not produce ADHD. They produce ADHD-like symptoms. Okay. Now, if you have a constant food allergy and you're ingesting the foods and it's in your bloodstream, you're going to have those symptoms classically 24 hours a day until you get rid of that allergen. But if you get rid of the allergen and the symptoms go away, it wasn't ADHD. That's what I'm saying. Okay. Most of us do like we just did. We get some momentary rushes from ourselves with donuts and Krispy Kremes and coffee, which rush us and get us through, but we also get a little jittery at that point. All of us have those cycles throughout our day and how we cope with them. Okay. That's important for us to take a look at. But if the symptoms weren't there in childhood before age 7, and I'm also saying if they go away when you change your diet, then I'm saying it's not ADHD. It's ADHD-like, and that may be academic, but the reality is it's different. Okay? It's different. And I think we need to take a look at looking at things as disorders of attention and disorders of impulse control and what's causing those disorders. And then we might look at the picture differently. And that's important. Okay. And there were some questions about, am I saying that arousal is really not a major problem? No, I'm saying arousal is a major problem. It interacts with inattention. Okay. So it is a problem we need to take a look at. But if the arousal problems are caused by something else, like trauma or affective disorders, then it's not ADHD. Again, it may be academically pure in that sense, but we owe it to the people we treat to give them the right diagnosis and the right treatment. Now, at some point, it may be the same. For example, with adolescents who are depressed and adolescents who are ADHD, it's not uncommon for me to see them on Effexor. Hey, it's the same. Okay, the treatment at some point is the same. But I think socially and culturally we need to take a look at that for ourselves. And that's very important for ourselves and how we treat them. Because we're talking about 5% of the world. Okay. It's not just 5% of the United States. Ideally, what we're saying is 5% of the world. That's a lot of people. Again, I'm very fortunate to do talks all over and do research all over the world. And it's really interesting what I've discovered, and this is, I'm probably going to offend somebody, so hang in there with me. But, certainly my German heritage likes social order. Okay. And so in Germany, we can see that it's a problem. Social order is important, and actually Der Spiegel has a nice issue this week, I think it's like Time this week, out on ADHD in Germany and the problems it's created. It's like picking up Time magazine 3 years ago. It's the same problem socially and culturally. The same issues. Are we over-medicating Germans? Kind of a thing. Now, if you've been to Germany, they drink beer at all hours of the day. And yes, you are over-medicating, but you're doing it yourself, okay? And then in England, it's the same thing, because obviously social order is very big in Britain. It didn't seem to be a problem in France, however, except it's in the classroom, it's getting to be more and more of a problem. Okay. But the phenomena we're dialoguing with here is going on in clinical meetings around the world. The same kind of issues are coming up, and the same issues that we're dialoguing. Huh?
What about third world countries? Is there any research done?
That's a major issue, because what we find happening is, if we take a look at the fact that inattention and arousal have neurodevelopmental roots, we're going to have a real problem, because most of these third world countries during the neonatal states are malnourished. We have automatically disrupted that cycle, which in turn will change some genetics and some cycle down the line. So environmentally, perhaps socio-politically, what we've done in areas is created probably 2 or 3 or more generations of individuals who are going to have problems with sustained attention and impulse control, in part because of malnutrition.
So, there are some people that say attention deficit is a creation of the Western wealthy world. You're saying it's like schizophrenia is worldwide.
It's what I think where the issue comes in is the sense of, if, like when I was a kid, I was on the farm, and you could drill with disinhibition by sending me on the cornfield. I didn't bother anybody. Okay, but in a much more urban setting, it becomes a problem, because inhibition is required to live in that society. That's why that statement comes up. More and more, we're aggregating to centers, and it becomes a problem. Because it's not that ADHD doesn't exist, but because disinhibition is a real problem in that culture and society, because of the way we have to live, it's more prominent. It's highlighted more. I could have it on the farm. It's not going to cause me any real problems. I just have to sit outside for a little bit during meals, but you can't do that nowadays. Okay. In urban, in city settings. That's, I think, one of the other problems. So you're right in some sense. It's a cultural problem, but it's cultural because of economic situations, we're living in more mass settings. Those mass settings require inhibition. If you don't have it, you don't do well. You don't do well. But your other point was, in third world countries, if we just look at safe factors, prediction is probably 5% of the population is going to have it anyway. It's not just the third world. Except as we look at that, what's happening with the world as it becomes globalized, inhibition is going to be necessary. You have to be able to inhibit yourself. So there is going to be a problem. And again, because of environmental factors of drought and economic situations, and then add political factors, we have several generations of individuals who are going to be impaired because of malnutrition during early childhood formation periods. And that's really incredibly sad. I just look at the big picture.
Are you planning to deal with the fact that
Well, I think the real issue, if we take a look at it again, I like to think there's kind of a lock and key to life mechanism, and that nurturing and bonding that we do with attachment does have dramatic differences on soothing, which produce neurochemical changes. Okay. So there is a disruption of that neurochemical change. Okay. Now, does that mean that attachment disorders merely are disorders of bonding that have developed? I think that's some of the older thinking on that, although it may be prominent, it may still be present. I think I'm from California. The literature is profound that we're almost at epidemic proportions on the attachment disorders and the autistic spectrums, reactive. It's almost like 5 to 10. No, it's almost like 10 to 20 times the expected ratio. Okay. Now, who would think that people from LA have problems with attachment? But the real problem is with children. It's a real mess. I mean, it may be like ADHD, it's overdiagnosis or other problems, but the reality is that the behaviors are mimicking it, even if it's a wrong diagnosis. There's a serious problem, which gets back into that other problem. Bonding is important, but we may have some genetic variance going on itself. You know, my current work is in two areas. One is on clinical cases. I'm doing work in genetic disorders, primarily neurofibromatosis, NF1 and NF2. And we know from them there are variant genetic factors, and those mutations can be spontaneous. Clearly, NF, for example, has linear traits, but it can be a spontaneous mutation. It may well be that ADHD has a spontaneous mutation occurring. We really have to start taking a look at that. And I know Stefan Pulst, the Warshau's chair of neurology at Cedars-Sinai, is looking at multiple probands of DNA. And he's actually been able to do a lot of this work through the graciousness of the Mormon Church and their data records and classification, because there's multiple probands usually living together in a similar area. And so we'll find out some of the early stuff, probably in the next couple of years. But we may find that there's spontaneous mutation occurring also. And that may be also what's happening here. There may be some spontaneous mutations occurring. But something is happening, obviously changing. The attachment disorders will again look like ADHD. Problem sustained attention, impulse control, fidgeting, and things like that. Obviously, they present differently if you look at the bigger clinical picture for ourselves. They present differently. I know there's something else. I was talking with somebody else, so if I forgot to talk about what we were talking about, please bring it up. Some major issues. Medication-wise, I think that was the other one. Again, what I really want you to focus on today is sustain this focus, if you will, on looking at your theoretical orientation for what ADHD is. I think that's a good grammatically clear sentence. In your clinical practice, you make this diagnosis. When do those flags go off? Oh, this is ADHD. What I'd like you to do is change that flag to say, oh, this is ADHD-like. What is the problem? This is a disorder of attention, of arousal or inattention or impulse control. What's creating that scenario? And then go into your formulation, then go into your assessments and everything else, rather than making the diagnosis automatically. It's really important. And taking a look at your orientation towards that issue. Okay. Now, again, at some academic point, you may end up treating them the same. Stimulant medications tend to be the medications of choice. You know, I think if I remember the NIMH studies that came out about 2 years ago to show that medication alone actually worked better than medication and behavioral therapy, better than behavioral therapies alone, and good news, better than placebo or no treatment. Okay. Now, that was an accumulation of studies through the NIMH. I don't know if that's going to hold true in the next 5 years. We'll take a look. I certainly don't encourage you, though, just to use medication alone. That family therapy training in me says there's a system that's been interrupted. It's not going to go away on its own once you medicate with Ritalin. It's not like the system kind of buries itself over. It's going to take a little bit of time to change. I certainly look at and encourage family therapy models. But again, if that family therapy model isn't producing an outcome, i.e. inhibition, there's a problem. Take a look at it. It's not working. Okay. It may be in the family systems model. It may be the parental subsystem. It may be the child subsystem. It may be the husband and wife subsystem they're reacting to. Pay attention to that. Okay. It's not working. The desired goal is inhibition. Kids with ADHD have problems with inhibition. They have problems with arousal at that point because arousal really is inhibition if you think about it. Okay. You're either inhibiting or exciting. Life isn't much more than that. It's kind of binary. Okay. In that sense, it's very masculine in that sense. Okay. Other comments or questions from the community about things maybe that I didn't address? Hmm?
It's great for talking about inattentive type.
Very good. The inattentive, that's right. If we look at the DSM-4 category, thank you. The issue is inattentive types. Now, Brown's model really does work good with an inattentive type. Okay. We have to take a look at this DSM-4 spectrum and realize that it's not uniformly distributed. If we've learned something about ADHD children, it's that there's variance. And there's going to be variability within that frame. It's not a nice model in that sense. There's no more of these and less of these. Okay. You have to take a look at your practices. And some practices, for example, tend to see more inattentive and hyperactive. They go to somebody else. It's interesting how practice styles work and referral bases work. And if you're familiar with parenting and parenting groups, it's kind of sometimes the inattentive groups get together and the hyperactive kids, parents get together as well, and then you get referral patterns out from those directions. Life works on its own, sometimes independent of what we psychologists want to do to it. And sometimes it works better without our help. But let's take a look at those patterns. It's not uniformly distributed, at all. Take a look at each subtype. And then the question gets in then, now that you've got a subtype, what are you going to do with it? Again, if we look at medication factors, typically methamphetamines, the stimulant medications, methylphenidate, tend to still be the medication of choice. Okay? Now, I'm not against the use of methylphenidate. Okay? It works. It's cheap. Okay? Another dialogue was about neurofeedback models and biofeedback models. There is some work, Lubar, Schwartward, and Schwartward, Deminsky, Borsnikov, no, that's somebody else, out of New York City, Long Island, have done some wonderful work looking at biofeedback and longitudinal models. The issue is though, I think where we begin to fall down is that not all ADHD subjects will benefit from neurofeedback models. So I think we need to start looking at which subset performs best for that model. I think that's the next step. We know that sometimes it works, sometimes it doesn't. Maybe we need to start looking at subtyping which kind of group, which kind of patient is best for neurofeedback models. Having said that, I have to be a little careful because some of those who do neurofeedback say that if you fit this EEG pattern, you're ADHD, independent of behaviors and history. That's a big no-no in my book, okay? There's no evidence for that. There's no historical evidence for that either, in the sense of, okay, it's now, but was that there before age 7? You don't know that. Okay, so it's some real clear problems. It may be one of those variables that tends to predict placement in research studies, but be careful on making it a diagnostic gold standard. Okay. That's the point I'm making. Sometimes it's just a nice predictor variable, doesn't mean it's a gold standard. I think there's any other ones from the community that maybe I've overlooked at? Continuous performance test. Let's take a look at this element, this type of test. if you mention, I said certainly history taking is a big thing. Record testing is you've got to do. And then you certainly have to look at behavior because you have to eliminate what it's not. But you also have to have something that really measures attention and impulse control, some measure of it. And as far as I can tell, where we're at with that is CPTs, or continuous performance tests, tend to work well at being measures of those behaviors. Okay. And as I kind of alluded to in the historical episode I went into about Donders and some of the work in Giertych in Germany and the history of psychology, is that CPTs really emerged out of that era. They didn't have computers at that point, but that's really the history. And then you heard me talk about this radar screen. Again, that's some of the history of signal detection theory. Those of you who remember those exciting classes on signal detection and D-prime theory in your graduate school classes. Really, CPTs have their roots there also. Okay. Continuous performance tests, again, are adequate measures of sustained attention and vigilance. They're reasonable measures of impulse control. The thing is, they are those two if they meet this last requirement. They are long and boring. Okay. If they're shifts of novelty, then what you're getting to is a different level of arousal and not sustained attention. You're getting set shifting. I have to be really careful on how I say those. Sometimes my Tourette's comes out. Element there. Okay. That's the component. Now, the test of variables of attention, Larry Greenberg is the primary author. We've done a lot of work on this. Is one that obviously I know a lot of. It's a non-language based stimulus. Typically, CPTs are, you have a computer screen and something appears on the screen and goes away. Something appears and goes away. That's a stimulus. Sometimes that something is what we call the target, the thing we want you to do. When you see whatever it is that is, you got to do something. For the Tova, you push a switch. For the Connors, you push the space button. For the Gordon, you hit this big blue button. Okay. For the Iva, you push the space bar. Something you have to do something. In other words, so there's a target task. Okay. We tend to use a non-language based task, and I'll show it to you in a little bit. There's classically what we know as the AX model, and that is that the, let me see if I can get into this now. And that is, appearing on the screen are letters, A, B, C, D, E, F, G, and so forth. And whenever an X appears, then the thing to do is, let's see if I can close this. Sorry for this here. Is an AX. In other words, on the screen, alphabet letters come out, and if an A comes up, and then the next letter is an X, then you do something. So that's collecting those an AX model. Okay, A, B, C, D, AX. Poof, you do something. Okay. Connors uses an AX model. Gordon uses what's known as a modified AX. He uses numbers, 1, 2, 3, 4. So if 1 is followed by the number 3, you push the button. Just a seamless model. We use a non-language-based one. There's a box at the top or a box at the bottom. The box is at the top. You push the button one time and only one time. But anyway, it's like that. So we use a non-language element to do that. What CP2's that is you have sustain. You have to keep focusing on the screen, and then stimulus constantly come up, and then you have to select the correct stimuli. In doing so, then, what most of the tests measure is yes or no. Did you identify the target as a target? Did you identify the target as a non-target? Or did you shoot down the wrong airplane, as I say? Did you make an error of commission? We also look at the speed of processing. How fast can you do that? Now, that's what most of the CPTs on the market do. Some of them, like ours and others, also have a next step, and that is the variance, the variability of the response time. for it. But that's basically the paradigm for what happens for a self. Now, the primary one came out of Roswell, Mirsky, and Saracen. Mirsky's name should be familiar. This is the one, the factor model I talked about. So Mirsky's been doing some great research for a very long time here on ADHD. He used the standard AX test. Now we get into this other thing called ISI. And that's what's known as an interstimulus interval. These are wonderful words. But basically, remember I said something comes on the screen, and then it goes away. Well, how fast does it come back up? That's an ISI. He used 920 milliseconds. That's almost 1 full second. Go away. Another second. Comes up, and so forth. Okay. We use a 2-second interval. Every 2 seconds, a stimulus appears. And that stimulus is either the target or it's not the target. On all of the tasks, it's the same, and that's the target or not the target. The Conners uses what's known as a variable ISI over blocks or epochs. Some of it goes 2 seconds, some of it goes 3 seconds, some of it goes 4 seconds, some of it goes 1 second. And then it shifts. It's not like you have the first quarter, then you shift to the second quarter, then shift to the third quarter and fourth quarter. It's variable within the task. So sometimes the task is every 1 second, sometimes it's every 2 seconds, 3 seconds, so forth. If you look at the database, and even with Keith's work, is that 2 seconds tends to be the best predictor. 1 second tends to be too fast for normals. Normals tend to get misdiagnosed. Too many normals get misdiagnosed. And at 3 and 4 seconds, too many people with real problems tend to be called normals. So 2 seconds tends to be the best optimal if you look at sensitivity and specificity, at equalizing the groups and prediction which group is doing best. Does that make sense what I just said? Okay. So we use a standard 2 second, but be aware that instruments do vary. And the tasks vary. One of the other issues then, if you're changing, you have to realize that sometimes you're getting a change in set shift, the ability to shift where you were to another level and then go back down. Sometimes that's the kind of research you want to look at and diagnose. When you're doing work with brain injury, that's an important component. Because if you look at healing and the sense of progress, certainly you want to be able to person, to be awake and look at you, but then you want levels of arousal that vary and the ability to shift when those arousal levels vary also. So sometimes, especially during head injury work, that's something you want to measure and look at it. And I say that because if that's really what you want to do, our TOVA test isn't the best test for you because we use a constant fixed interval only. Okay. I think then the work by Joe Sanford in the IVA, Intermediate Variables of Attention, if you're doing brain injury work, is really the best one to use. And actually his work grew, the IVA grew out of some of Sanford's work looking at brain injury and rehabilitation. And if you're doing that kind of work, you may be familiar with the work by Brain Train, and there's rehab programs like that. That's the history of the IVA in that sense, and Joe's done a wonderful job on that. But most of us aren't doing that. Most of us just want to know, does a child have problems with attention and inattention and impulse control? So we take a look at that. Again, what Roswell and Mirsky found is that they really did do well at predicting. And it was from this that we began to look at things. There's a great classification rate. The AX model found to do better than anything else that was there. Okay. Again, the Riccio book that I talked about earlier, over 400 articles they found using CPTs of any kind. Now, one of the real difficulties in doing research on CPTs, in the sense of literature research reviews, is that it's actually, if you're an average programmer, you can create your own CPT and use it for your study and get rid of it. The programming isn't that difficult. You can get a letter to come on and go away. It's not that difficult. And a lot of the work with medication studies and a lot of the work with pilots and other kinds of work on CPTs have what I would call kind of these disposable CPTs, done for the study and then tossed. Okay. The difference between the Conners, the Gordon, the IVA, and our test, the TOVAs, is that we haven't thrown ours away. What we've done is collect lots of norms on them. We've created a standardization base for you. That's really the big difference. But when you do literature reviews, just be aware that you're going to get a lot of one-time trials. And it's hard. Then The other thing is that it's hard then to make generalizations from that research at that point. Okay. But there is an extant literature base on CPTs out there now, to say the least, for yourself. Now, what makes the difference on CPTs? All of these at any one time and interactions there within. We have to look at stimulus presentation, i.e. is it alphabet, AX, is it 1-9, is it boxes like we use? Is it the ISI, 1 second, 2 second, less than 1 second, greater than 2 seconds? That comes into place along with the stimulus. Is it the stimulus modality, auditory, visual, and so forth? Do some of them distraction models? Again, the nice part about the Ivan, it's a competitor of ours, but he's done a nice job, and that's why I think it's great for brain injury, is that distraction is something he builds into it. Gordon's done the same with his Gordon diagnostic. There's a distractor element. And if you're doing work with brain injury, you want to see, can they handle distraction? Okay. Distraction in and of itself hasn't proved itself or proven itself to be a great predictor of ADHD on CPTs, is why I make that caveat to you, if we look at predictor variables alone. There are some adaptive CPTs. In other words, it's kind of like, well, most of you know aren't going to be taking the GRE, but they've gone to the computer-based ones. And so if you start getting 5 or 6 items correct, you get bumped up a notch. And you have to take a harder task. They automatically do some logarithm and boom you up a level to harder levels of difficulties. That's an adaptive model. Most of us took the GRE, you could go back and forth through the pages, and I prefer that model myself, but nowadays these youngsters can't do that. You start doing well, you get harder tasks, then you know you're doing well on the task. I tell my students, if you start getting easier questions, you goof somewhere, pay attention, get the next 5 right, and then you'll get bumped up a logarithm. Okay. But that's what's known as an adaptive CPT. Okay, they're doing poorly, let's slow it down, change the rhythm, change the interstimulus interval, change the distractions, and get them to be successful. Okay. The length of task is clearly an issue. The Connors itself is between 12 and 16 minutes. Our task is 21.9 minutes long. Our goal was to create a very long and boring continuous performance test, and I'm very pleased to say we met our goal. Okay. Now, having said that, those of you who give the test, I just said it's long and boring. Bring your fantasies with you when you're in the room with the child. You're going to need them because it's a very long and boring task. Okay. And we did so on purpose because we don't want shifting of attention, we don't want novelty, we don't want distractors. Can you maintain yourself for over a long period of time? And also the target to non-target ratio varies. Again, with Keith's work on the Connors CPT, Keith is really a wonderful man, a very gracious gentleman. We were very fortunate to have this big powwow at Cambridge one year with Keith and Mike and I were presenting on our CPTs. And Keith starts his off with, well, we have the CPT. So the Connors is called the CPT. We just have a CPT. We're just not good enough to rise to the level of the CPT yet. But the CPT uses a variable ratio of targets. In other words, it varies. We use a fixed model. In other words, there's 3.5 to 1 ratio in our test. In the first half of the test, there's 3.5 non-targets for every 1 target. The other half of the test, 3.5 targets to every 1 non-target. So when you look at CPTs, look at those kinds of things. The other thing I say is that when you're doing the analysis of interpretation of the test you use, look at those things also. When the target to non-target ratio changed, if you're using a test like that, how did the subject do on that? Okay, you have to take a look at those factors for yourself as well. But these are the variants of all CPTs. And I can tell you that changing any one of them changes the discrimination ability, i.e. the predictor ability of any one of the tests. Okay. Changing 2 of them, you'll logarithmically increase the ability of change and prediction itself. Okay. So always look at the norming standard and what was used for prediction into ADHD or abnormal kind of groupings. Now, before I forget to say this, why am I talking about CPTs? Well, I talked about the ability to measure sustained attention and arousal. These are really the components, again, that we look at. This is inhibition and arousal. Inhibition is measured through commission and omission errors, as well as consistency of speed. arousal is, again, related to the factor of the length of the test itself. What do we know then? I'm going to go into each one of these. Stimulus presentation. That was the first thing we talked about. There's an X-type task. It's an easier. Just if an X appears, you push the button. If you overlay that with inhibition task, i.e. there's an A and an X, let's just say we use an A task and then an X follows afterwards, that requires some inhibition. Whenever you see the A, you have to wait, make sure it's not a B, or a C or D and E, F, G, H, all the way through the letter X, okay? So there's inhibition involved as well. So it's a little bit more difficult than the basic task. Sometimes there's two X's appear in a row. Again, that's similar to AX. It requires then inhibition. You can't just push the button at any X. You have to wait to make sure there's an X and an X coming up. Okay. Again, the Gordon uses the numeric variation of that. It's a 9-1-9, or with children a 1-3 kinds of tasks. Now, back up. We use the variant is, again, it's just a box within a box. And so let's say you see what the little X is like within that little box. We have a white box around something like that, and there's a box on top, and sometimes it's at the bottom. That's all we say. We have a non-language base. And theoretically, that's important because if you look at the literature base on comorbidity, there's a serious problem with comorbidity between learning disabilities and attention deficit disorders. Depending on who you look at, there's about 20 to 40% chance of either one occurring when you have the other one. Okay? It's not that LD causes sustained attention problems, and it's not that ADHD causes learning disabilities. It can confound learning disabilities. They're not causal, they're comorbidly related to each other. Okay. Mm-hmm.
There seems to be a subtle difference between responding to CPX, like the Connors, and responding if you see a 1 and then a 9. Does that come up in the research literature that memory components there?
It's mixed. It's mixed, but I think you're right. It gets into that. Remember we talked about encoding, rehearsal, and retrieval. That's also important. To have that, you have to have inhibition. Each one of those steps requires inhibition. It also requires arousal. The thing to do is come.
Like just the X type theory of the side,
Mm-hmm.
and the other would be there's a longer.
Right, and sense of size patterns and things like that, right. What the other point to bear in mind is that language disorders confound that then. If you have a language disordered child, I would not encourage an AX or a 1-9 kind of model. It's just one of those things that compounds the factors for yourself. And the other thing, obviously, if you're using children in different languages, be aware of that, okay, for yourself. Let's talk a little bit about ISI. Again, as I mentioned, Roosevelt, Versky et al. Used 920 milliseconds. Some getting from 50, that's pretty quick, 50 milliseconds. It's pretty quick. Figure 1,000 milliseconds is almost 1 second. Think about almost a half of a tenth of a second. That's pretty fast. Okay. Now you want that in your fighter pilots. You want that in your airplane pilot when you fly home. But that's a little hyper-arousal, hyper-alertness, that the rest of the population, and I guess if you're from Canada, you certainly want it in your goalkeepers playing hockey, okay? You want that fast. But most of us probably don't respond that well. I mean, there tends to be a select group that can form that well. And what happens is normals tend to get misdiagnosed, or misclassified as attention impaired when you have the faster ISIs. So there's an optimal trade-off, okay? Again, some tasks vary. So there's a variability of ISI within the task itself. The other thing that's related to ISIs is this SOA, the stimulant onset asynchronity. These are wonderful terms for you to use at home in your practices. Basically, it's that lingering effect. How long does it stay on the screen? I've talked about appearing every 1 second. Ours goes every 2 seconds. How long does it stay on the screen is another thing. The longer it stays on the screen, the better the chances are it's going to be detected. So the faster the SOA and the faster the ISI, the more difficult the task that it is. Okay. So those are the other things you have to take a look at within the CPTs that you're using for yourself. And also then the other interactional component is that SOA variable with the ISI. So you have interactional problems as well in predicting. Again, typically said, the longer the SOA, the longer the ISI, the more likely people are going to detect the stimulus. Okay. The shorter, the less likely. The shorter it is, the more often normals are going to be misclassified as impaired. So again, your hit rates or sensitivity and specificity get to be a little distorted at that point. Okay. The other thing is that one of the reasons is shorter SOAs increase omissions. You missed the target. It didn't stay on long enough for you to see if it was a target or non-target. So not only you may have increased kinds of things of commission errors, but you're going to miss them also. So you have to take a look at the literature based on what's being said. You increase the ISI, you increase the SOA, you also tend to have slower response times. That just kind of intuitively says, if it's only on there for half a second, and it only lasts, and another one comes up in a half second, you haven't got much time to respond. So your latencies of responding, that wasn't, sorry on the tape, that wasn't very good grammar, but you don't have much time to respond. So you have artificially higher response times on the CPTs. And that's important as you look at the literature base and do your lit reviews on what CPT was used in which study and trials, that stuff becomes important. Again, not alphanumeric on the modality. Is it auditory versus visual? Often the auditory AX models are literally that A, B, A, X. They're just read all out. Okay. We use a tone. A middle C is the non-target, and G above middle C is the target. And I'm very tone flat, so I'm not even going to try to go there with you on tones, but basically it's beep, 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 beep. So you have some arousal, you have some recognition of a higher tone for yourself. And the responses to these vary also. The data shows that all auditory tasks are harder than the visual task of the same test. So if you look at the norming base for example, the Gordon's auditory, you look at the database for the auditory Gordon, the normals make more errors on the auditory tasks, and their response times are longer on the auditory tasks than the visual tasks. So within the general public, auditory tasks are harder also. Okay, and the norming base reflects that. Mm-hmm. For those of you who are listening in your car or you're home at this point, the question was, does the literature show that ADHD subjects are better with visual tasks or poorer with auditory tasks or the other way around? And the question is, they're pretty poor with both. The answer to that is that if we look at just predictability of classifying ADHDs on the visual task, clearly you can do that with the visual items. And you can do that with the auditory items about equally. Okay. Again, if we look at Russell Barkley's work, he says about 20% of those with real ADHD probably have auditory processing difficulties. And at that point, you probably might be best using, if all your history and everything else points to an ADHD child, then you use a visual-based CPT, and it comes back within normal range, you might try the auditory modality for yourself as a double check. Okay. Again, multi-trait, multi-method converged to the other is the best model. Okay. Distractions is another aspect. It was one of those things we take a look at. We have the task coming up, and then does something distract you from that? Now the Gord has 3 little screens, so the subject focuses on one and then 2 things. There's other numbers flashing at the same time as the 1-9 is flashing. Okay, that's a nice distraction model. Okay, it has a different norming base. Our TOVA doesn't use that. We just used one fixed model.
The Connors doesn't use distraction either. The IVA does use distraction, as it does. Again, the real goal is to increase the varying levels of difficulty. Okay, that's the task. And where does the problem fall? If you increase distractibility, does the subject's performance wane? That's a good predictor for you. Okay, take a look at that. The distraction varies. It can be degrading. In other words, the stimulus appears and then fades away. It can be a normal stimulus and it begins to fade away. It could also just be a blurred stimulus from the onset. So there's multiple models of distraction. Obviously, visual distractions are more common for that test than auditory tests. Auditory tests tend to have auditory distractions and so forth. Okay. So varying levels of distraction. The adaptive CPTs are also something to take a look at. Again, as I alluded to earlier, let me just say again, it's just like the new GRE. You do several in a row correctly, you get a harder task. Okay. You start doing poorly, you get an easier task. So they adapt to your performance. Those tests, those adaptive CPTs, don't do as well in predicting placement into ADHD or normal groupings. In part because of the adaptive component. The length of the task. There's a 3-minute task. Bremer reported in '89, his mini CPT. And then he doubled it to a 6-minute CPT. Again, it's kind of like behavior. If you have less behavior, it's harder for you to make a prediction. The more behavior that you have, the better prediction you can make, generally speaking, about anything that's going on in life as a psychologist. So what you want to do to make a better prediction is to see more behavior. Okay? Therefore, the longer the task, the better prediction rate. The shorter the task, the less prediction rate. Okay? Just keep those general principles in mind for yourself. Ours tends to be the longest. Okay? Again, we set out and we met our task. It's a long and boring test. Okay? Again, the ratio then varies for ourselves. The presentation of the targets. Again, we use a fixed 3.5 to 1. Keith uses a moderating ratio. Mike's is a pretty consistent, although it varies on his distraction task. The IVA uses a variable ratio. Some use mixed within a variable ISI. Some match the ratio to the ISI and have interacting components there. Again, our TOVA tends to be fixed, 3.5 to 1, throughout the length of the task itself.
What's the difference between the TOVA and the TOVA 8?
The only thing is the presentation of stimulus. It's actually the same paradigm, 3.5 to 1 non-targets to targets, 3.5 targets to non-targets. The only thing is it's, as I said, the tone and the top. For example, the visual TOVA, when the box is at the top, that's the target. There are things that also influence CPT performance. Okay, this is very important. The directions. Is the examiner present? Our thing, the TOVA, is if you follow standard instructions, you have to be in the room. And that's important because if the kid drops the button, picks it back up, there's going to be more omissions. Remember, you have to count for the variance. How come the performance varied? Because he dropped down, picked up the button. It's different than him staring at the screen missing of them. Okay, so examiner presence is important. Prompts and cues are important. Okay. Obviously, anything that's going to affect sustained attention impulse control is going to affect the test. Caffeine, anxiety, depression, alcohol, all going to affect things. Okay. You know, use some of the things you learned elsewhere when you do a test. Remember that. The environmental distractions. Ideally, if you're doing a CPT, you don't want to do it in the room with your cell phone ringing, your pager going off, and everything else. Now, you don't want an Ivy Tower dark room necessarily, but make it a little bit more real life in that sense. Make it more classroom-like. Okay. What I want to do is maybe spend about 5 more minutes because then we really need to close down. There are 4, as I mentioned, CPTs that have emerged on the marketplace. As I said, there are thousands of them out there on studies. And there are a lot of those disposable CPTs, as I said, used in studies, but 4 have really, and they're just an alphabet, the CPT, as Keith likes to call it. The rest of us are just a CPT. Connors has done a wonderful job. The GDS is the Gordon Diagnostic System. The IVA is Intermediate Variables of Attention. And then the Test of Variables of Attention, or the Test of Variables of Attention auditory version. Okay. Are you there? I think I have a slide on each one where it's from multi-health systems. And you can see me afterwards on this. And actually on your slides that you have, you'll see on each of the CPTs, I've organized the slides to address each one of those 8 points. Do they use distractions? What's the ISI? What's the ratio? What's the stimulus presentation? So each one of those initial 8 points that I started with, I address on each of the CPTs. So you can go through and see which one has which and what it does for yourself. Because we only got about a couple minutes left. So I have about 11:46, 47. Is that about everybody else's? To make sure I'm not in a different time zone. Okay. For example, this kind of slide deals with type modalities and things like that. They're on each one and things. So I tried to be pretty neutral. Again, I highly recommend the Riccio, Reynolds, and Lowe book because it does a nice job in 2 parts. One, it's summarizing all the work on ADHD, and then also summarizing all the work on CPTs. Okay. General comments and questions?
We read about a new non-stimulant medication that's being tried in the States. It's called alomoxetine or something like that. Are you familiar with that?
I'm not familiar with its properties, but I am familiar that it's being used. There are also some other what's called newer medications coming out. Those tend to be the same methylphenidate-based medications with different transportation mechanisms. And what I mean by that are skin patches. What we do know is, for example, that sustained-release dexedrine, for example, it really is not really a good medication of choice, in part because it's dexedrine, but also because the transport mechanism, and that might mean dexedrine uses a wax-encapsulated model. The problem is that by different metabolisms, it's not a steady state going into the bloodstream, but you get these bursts all the time. And so out of that, Adderall then was created, which is that double methamphetamine cluster with an L-isamine binder, I think. But what it also does is it has a much more steady state dissipation. So it starts out effective, and it just slowly drops down and lasts typically 6 to 8 hours versus 4 to 6 for a basic Ritalin. So what are some of the newer medications are just transportation mechanisms, getting rid of the wax encapsulation, a patch, things like that going on. Although I can just see now, those with speed problems ripping off skin patches off little poor kids. But what happens is the transport mechanism really sometimes makes the dosaging different. But I'm not familiar with that one. The other thing is that if we look at the work by Brown does a lot of work with medication trials on such things as Effexor, Wellbutrin, and other things like that, because they're not necessarily inhibition-oriented or dopaminergic-based models. They tend to be more serotonergic-based models, which gets into his theoretical orientation of arousal and things like that. Okay. And things like that. Other comments or questions?
Are you familiar with the test of everyday attention?
Yes.
Not computerized thing.
Yes, it is. Yeah.
What's your opinion?
Again, what they try to do is use a CPT that has a variable ratio, variable ISI, with distractions. Because that, theoretically, is how we live our everyday life. So that's really the theoretical orientation. Again, it tends to predict yes or no. I think it tends to be used more in models where brain injury rehabilitation is a critical issue for yourself. In that sense. But it's theorientation because it uses variable ISI, variable SOAs, and distractors. It tends to mimic their idea was everyday life. Psychometrically, I think they could use a little bit more, and they could use a little bit better reliability and stability issues, but those are things to address elsewhere. But I think they've done a novel job with it. I'll be available for some comments afterwards. It's about 10 minutes to. I need to, because the room is going to be, I think, after lunch or something else. Was it 12 o'clock? Is that the next show, or is there an hour break or something? Lunch? Okay. Here.
I am curious about how this topic found its way into this conference. There was something I said.
Mic off.
I thought it might be a thank yous.
It's the same way one of episodic discontrol is that we're also some very good friends with the folks at Trinity Western University. And both of us have done some wonderful presentations up there. And the folks on the faculty are really wonderful people who said, hey, can we work with you? And they said, come on up. So we're easy, we're cheap, and we're here. The next time we're going to do this is I'm actually going to start collecting some literature and everything else and make it a little bit more tied to meaningfulness and look at the literature reviews on arousal, sustained attention as meaningfulness increases as value to make it a little bit more tied to the model.
I thought you might have related it to fragmentation or something like that. Fragmentation of meaning.
I'm German, I'm pragmatic. You know? That James part of me still exists. The wonderful folks at Trinity Western, they're always very kind and gracious people, and my lesson and I enjoy being with Derek and Dr. Wong and others. And we also know one of the board members at the university, so that helps there. So it's usually more pragmatic issues than theoretical issues that take hold. But yeah, I'm not kind of the guy who so to speak. But thank you for coming in, even though it's not directly related to the rest of the conference. I'll see you folks after. I'll be here later tonight as well. Maybe have a glass of wine or create some additional difficulties later. That'd be fine. Yeah, CME people, I think, need to CE period. That's right. We're not medical education units.
That's another question.
Sure.
Has there been any research done on subliminal differentiation?
That would be one of those distractors that degrades. Yeah, it's a distractor. Think of it as a distractor variable.
Okay. I guess my question is, I'm not using the right term, but when they flash something on a that's not recognizable, you're not aware of it, but you also get this hunger for, Oscar Mayer or something of that sort.
Well, that appears, but it's not as a stable base, and it's not as great predictor.
Okay.
It's not as a controlling influence, but we do know that they do produce some kind of arousal differences.
But I'm just wondering, do ADHD kids recognize or?
I don't have a literature based on that.
Okay.
It may be that they focus more on the subliminal and less on that, but I don't have a research base to share. It may be there, I'm just not aware of it.
I'm just wondering, is there a threshold, a firing threshold of the neurons that is decreased for some reason?
Again, I'm not that familiar with the literature base, so I don't understand that. It may well be.
Yeah.
It may well be.
Which would be the basis for medication.
Exactly. It may well be.
Okay.
Excellent. Hopefully I'll see you later.
Yeah.
Thank you.
I'm looking for a doctoral thesis, so.
Oh, please.
Yeah.
That'd be fun.
If you got any ideas, that'd be.
Oh, sure. And if you want to use our total, we can usually make it available for
Yeah.
research. Just, we charge a previous fee, but for research, it's
Yeah.
like $200 flat rate.
Okay.
You have my email address?
I work with adults. Yeah.
Yeah, just give me one.
Yeah. Good.
Sort of ask.
Oh, thanks.
Another copy here.
Oh, sure. You want me to send it to you? Sure. Feel free to keep in touch. Thanks.
This is terrible. This is personal. I just have I need an expert help. I have a daughter, she's an engineering student. She's done 2 years now, but she's having a rough time with it. So what do you do?
I would get a good evaluation. See, I actually treat some physicians, for example, even now, and I have them on Adderall only when they're doing, which is a stimulant medication. But they only take the Adderall when they're doing their journal reviews, not when they're doing their medical care. So with Adderall, she can just take it when she's studying, and not give her double times. I don't, but you can email me just at HIV. Do you have your card with you?
Okay.
I didn't either. Let me see. You know what?
I'm sorry, I was not prepared.
No, I did not. You know what? I think I
expect.
have one. No, we're not. We're trying to where she can feel it. Yeah, come to that. Because it gets you to the school, right? One thing nice about this doesn't is that they dissipate for all the
I don't know. It breaks my heart. You see her.
Yeah, every child is different.
So, it's got a very small conversation. Right, exactly.
Yeah, and what's nice about it, again, everyone, is that we take it 6 hours inside the courses. Yeah, oh, that'd be wonderful. Spend everything else and help till it grows in there. Just, you know, it's actually a pretty, to your sharp edge with that, so it should be here. Should be. Wilshire? Yeah. I don't think blacks are welcome on, but I think it's Wilshire. Oh, you're quite welcome. Thanks for asking. I hope things go well with her. Grab some lunch? No,
I thought you disappeared.
didn't duck out, no. Just gonna try and put things away.
It just occurred to me, the LA stats you were talking about made me think of what Tom Brown was saying about Silicon Valley and Asperger's. You know, he was talking about the genetics of it and that sort of thing, that I can see sort of real possibility for either of these arguments.
Of course, yeah. Trying to think if I want my disc up here. I have my disc too. There it is. Upstairs. I'm going to let them know it's here. Yeah, you have to show yours now.
Doesn't look like it. I'll probably plug mine in. I have my stuff is on CD.
Oh, okay.
So, but that's cool. I can. It should. It's. What is this? This is a. This is Gateway. I have a Dell. It should.
Yeah.
Those are the nightmare. The day when for then, like you find out